Good morning, everybody. I think I've at least emailed most of you. I'm Arthur Ollendorf. I am the DIO of Carillion, and I am welcoming you to our core curriculum. And just for some context, I'm going to frame this for you. Why do we do core curriculum? Because it's the right thing to do. It's to give everybody some sort of basic knowledge and some context to all the things that we do in, at least in this iteration, health system science and its related fields. We are really fortunate today to be talking about patient quality and safety. Why it's really important is something I've done in my life for a while. It's also really important because it's a good time to reflect on the fact that we are having a clear visit with the ACGME, a clinical learning environment review, and some of you may be involved in that directly, and I thank you ahead of time if you are. And part of it is how we coordinate what we do on the education side and what we do on the clinical side. And that's why today's talk is actually super fortunate and timely, but also being presented by someone who really understands this to a great way. So Branden Robertson will be our presenter today. He is a director of quality and safety for Carillion, but his previous job is he was actually our embedded GME quality safety person. So he understands GME and quality and safety and his overall quality safety in a very unique way. So we're so fortunate to have him working on the quality safety side, and he has this true passion and love for graduate medical education. So I'm excited that he will be sharing his knowledge with us, sharing some new things that are coming aboard on Carillion that you will should be aware of, but also can help make better. So with that, I will ask Branden to start his talk about patient quality and safety. Thanks for coming, Branden.
Yeah, thank you, Dr. Ollendorf. Good morning, everyone. I am going to attempt to share my screen, and we'll see how that's gonna go. Can you see my screen?
Yes.
All right, all right, perfect. I would turn my video on, but I don't know where the button is, so we'll just go with, oh, there we go. We'll go with that. Good morning, everyone. Like Dr. Ollendorf said, my name is Branden Robertson. I'm the Director of Quality and Patient Safety for Carillion, or one of them. And this presentation was put together really in collaboration with many folks, but largely Pam Booth, who's the Senior Director for Quality and Patient Safety across the system and accreditation readiness, and John Schumacher over process improvement and project management. And you'll see some of the tools that we'll talk about as part of his work, and some of the things that really you should know as a practicing provider, either at Carillion or any other health system that you go to. So a couple objectives. I realize that some of these things are probably things that you may know about, but we'll dive a little deeper into some of them. We're going to discuss healthcare quality. That's not as clear as it sounds, what the difference between quality improvement and quality assurance is. Quality assurance is this negative connotation that many people associate with healthcare quality improvement, which is truly not the same whatsoever. We're going to talk about systems thinking and how to try to kind of look at things from a broader perspective and how one thing impacts others. High reliability, how we in healthcare need and can transition to a highly reliable industry. We're going to talk about a proactive safety culture versus a reactive culture, and what your role in Carillion's culture is. And I'm talking about Carillion specifically, but you know, while you're here at our institution, this is the kind of culture that we want you to have and want you to be part of. Although understanding that many of you may not stay at Carillion, but these things are translatable regardless of where you go, or even open your own clinic. All these things can and should follow you. We're going to talk about a couple of problem-solving frameworks. So again, things that you don't necessarily have to only apply in your work at Carillion. Some of these things you can kind of think of at home, and we'll talk about some interesting ways to look at those problem-solving frameworks. We'll explain to you fishbone, FiveWise, brainstorming, and some of these other principles. And we'll also talk about a proactive risk assessment approach. Largely at Carillion, we use a failure modes and effects analysis, so we will get into that as well. So what's in it for you? Well, Dr. Ollendorf mentioned part of this. First of all, it's best practice. CLEAR tells us that we should teach you these things, and it is a graduation requirement to learn many of these pieces, but also many of you are going to be doing research. So this is going to help you with that. There are career paths within many of your career that may take you to the quality work. Our chief quality officer, Dr. Susie Kramer, internal medicine provider, and her career path took her through quality, and now as the chief quality officer still practice obviously as well. You'll have a better appreciation for the complexities in healthcare delivery and what role you're going to play. But ultimately, as we go down through this, what's in it for me, it's you being that you live in this area. Maybe you seek services at Carilion, or your family seeks services at Carilion, your loved ones, your neighbors, regardless of whether you choose to seek care here or whether you're involved in a motor vehicle accident, and that's where EMS takes you. Our ability to provide high quality care and your piece in that is important to you and your patients and your family, again, and your neighbors, at least while you're here. So we kind of ask you to be mindful of these things as we go throughout the presentation, and think, is this the type of care that I want delivered to me and my loved one? And if not, what do I do to impact that? So this is a little bit of what I talked about, this negative connotation that we worry about with quality assurance. So if you look at this, quality improvement is the future of what we're doing. Quality assurance is the past in a couple different ways. One being that old mentality of thinking about quality, but also in the retrospective nature of quality assurance. So quality assurance is this monitoring and looking for problems, and it's focusing on mistakes. It's focusing on where the problems exist and how you go fix that problem. And you're looking at problem prone areas. So in the automobile industry, you know that if this one piece of the assembly line generally produces a bad part, you monitor the quality of the product there. And again, it's retrospective. That's not where we want to be in healthcare. Certainly, I wouldn't want to be on that retrospective side, being that, oh, there was a problem with the care that we delivered to Branden. Then we need to just look at how we can do that better in the next time. On the right side is where we at Carilion want to focus, and again, where you will play a role in that is quality improvement, and that's where systems or processes are in place that will affect our performance today. These are the things that we want to make sure that people tell us about when their problems exist, when problems almost happen, so that we don't have to have this quality assurance program looking at when they do happen, but yet someone telling us about the fact that this is a problem, this could impact the patient later, and we fix it ahead of time. It's focused on outcomes and processes of organizational services. So again, we're not looking at the mistakes. We're looking at our systems and processes that allow those mistakes to occur. In the automobile industry, yes, they're going to go fix that problem, but they're just going to pitch that incorrect part away. In healthcare, we don't pitch our incorrect healthcare delivery away. We have to go fix it on the backside. We have to go handle that patient through additional services, additional medication, additional procedures, whatever it may be. But then we still have to take a step back and say, what led to this, so that we don't impact our patients later. It's related to high risk and high volume. That's healthcare. Regardless of how you look at it, every piece of healthcare is high risk. All of it is high volume. And in healthcare, everything is problem prone. So we have to look at that through the same lens. And this, again, this concurrent data collection and proactive risk assessment. Again, we'll talk about and failure modes and effects analysis in a little bit, but it's not this retrospective review. It's continued ongoing quality improvement that never ends. If we improve today, we'll improve again on it tomorrow, and we never rest on those laurels, is really the focus on quality improvement. So how is quality measured? We used to do a little scenario in this session where we ask folks to pull out their phone and look at these different websites and look at Carillion, and imagine that you're in California, you're across the country, and you have a family member living here, and look at Carillion versus some of our peers, including Lewis Gale, for a family member who maybe needs a hip replacement, and look at these four kind of data measurement systems through AHRQ, News and World Report, CMS, and Leapfrog. And where would you recommend that your loved one go to? And so we did this scenario because every one of them showed a little something different. Some we would be rated well, and some not so much. And all kind of understanding that every system has different methodologies and different criteria, different time periods of what they're looking at, and you have to take that with a grain of salt as a community member. But not all community members do, and they don't necessarily understand that. But as a healthcare provider in an institution, these are things that you need to understand and need to know, that data is the quality and data measurement is complex. It's difficult. It's typically lagging. There are conflicting indicators. There are conflicting criteria in many of these industries that are serving as quality and governance oversight healthcare institutions. And if you look at this, there are different performance periods. You really don't need to pay attention to the details on this slide, but it's really just indicating that there are several of these structural programs that are here in order to provide either input or comparison for healthcare institutions, as well as publicly reported data to our patients and to our communities. Some of those are being hacked programs through CMS, value-based purchasing, the hospital readmission program. Leapfrog is a big one, US News and World Report, CMS stars, and every one of them are looking at different metrics and numbers, and the performance periods differ. Now, obviously, this slide is a little old, looking at 2019 there, but you'll understand that each one of these, although publicly reported somewhat within the same year, looks back different periods of time. So when you're improving quality and you're improving what you're doing, you may not see that on a publicly reported platform or any type of comparison data for maybe a year, maybe longer, maybe 2 years in some cases. So understanding some of that is really helpful. And not everything that counts can be measured, and not everything that can be counted counts. And this is, really the case in healthcare in many ways. You can look at things in many different paths, many different lenses, and get some different answers. So understanding the metrics that you are seeking, and the caveat around and making sure that there's a caveat around the criteria and exclusions and timeframes is really vital when you're doing some of this comparison and understanding quality in healthcare. So in healthcare, all of this big data that we just talked about, the financial factors associated with that, much of that's publicly reported now, and then patient care, and then that leads into this complex confusion. And what am I supposed to be doing as a provider? I have to deliver high quality care, and then I have to also understand that there's this data that's kind of overlooking down on me, and I have to make sure that I look well there. And there are these financial factors that I am looking at, making sure that I have volume, so that I make money and I get bonuses this year. So all of these things are in your mind as a provider, and will continue to be that way. And it certainly causes confusion, but really there are a couple different ways to think about this. And the easiest way is following your institution's quality plan. And I'll talk about a little bit of the way that we do that at Carillion. And again, it's important while you're at Carillion, but this is translatable regardless of where you go. So this is just putting some of that other data on display. You do not, again, I realize that this is difficult to read, but I just wanted to show this here. In Leapfrog alone, there are all of these metrics that they're looking at in order to give us our safety grade. And then on these other programs, there's CAUTI, CLABSI, C. diff, MRSA, surgical site infections, and all of these other places, or these other either healthcare acquired conditions or infections that are in several programs. CAUTI alone is in Leapfrog and QHIP and CMS readmission. You have CLABSI and similar, and all the way down there. And then you have your nursing communication, which I say you see there. You're probably difficult to see it. At least I can indicate it because I know what's there. But the nursing category there is also impacted by CMS and Leapfrog. So understanding these type of things and the impact of why an institution selects these items on their quality plan is important, but also understanding what the repercussions of each one of those categories and what programs they impact is helpful for you as a provider. And knowing that when we're working on these things as an organization, it's not just impacting me. It's not just impacting the colleague in internal medicine or family medicine. It's impacting the trust that we have, that our patients have in us. Because these things are publicly reported, as well as it allows other institutions to benchmark against us, just like we benchmark against others. So, and I just kind of talked about this, but in a CAUTI alone, there's financial repercussions to this. So I talked a lot about how it impacts us and our reputation and our publicly reported metrics and our comparison with others. So there's also a financial penalty to the organization when we're penalized because of our performance in some of these areas. Anthem and QHIP, this is a couple of years old, but you can kind of understand that the finance associated with these can be high. You're looking at close to $1 million in some of those penalties just listed there. And again, all facilities and the U.S. News World Report and some of these other rankings also impact us in a publicly reported way. Again, folks losing trust on us, which also has a financial impact in and of itself. So at Carilion, this is what it means for us. So the quality and patient safety team puts together a quality plan. This quality plan is important for you to understand for a couple different reasons, because ACGME and CLEAR tells us that our residents and fellows should be aware of what our organizational quality plan and our quality goals are, but also you as residents and fellows provide the majority of the care that we deliver within Roanoke Memorial. And because of that, you have the great ability to impact and help us improve our metrics here. And we're not just improving metrics, these are patients behind these. And your program directors can actually get information related to the patients within your service line that impact every one of these metrics. But you are delivering the majority of the care that we're delivered at Carilion. You have the ability to impact these. Even if you're not a surgical service, I'll go down some of these, a surgical or internal service. Folks like, dermatology and others, you still have a place in this. And some, I think there's a connotation of some folks that I only work outpatient, this doesn't impact me. But that's certainly not the case. And so bear with me as we go through this. And I'll also look for any questions anyone has as we do. So for the 2023 quality plan, many of the things that you just looked at and saw that we're reporting to U.S. News and World Report and Leapfrog and others are here. And so one of those are decreasing hypoglycemic events, blood sugar less than 54 for patients who are receiving insulin. So we're looking at the previous years, we're finalizing dates on that, reason being is CMS changed their metrics. So we're staying ahead of that they actually changed it for next year. So we're staying ahead of that and updating our target for that. But we need to make sure that patients are delivered insulin in a a way of best practice and not dropping their blood sugar below 54. And unfortunately at Carilion, that's happening a lot more than what we would like. And that's why it remains on our quality plan so that we can have oversight of that. So be mindful of that as you're prescribing insulin and make sure that you're using the appropriate order sets. Reach out to your faculty when you have questions around that, because it's certainly impacting our patients. We also know that it impacts our next metric, which is the mortality rates, the achievement of the target sepsis overall mortality, both overall as well as sepsis. So these are reducing sepsis mortality rates, looking at observe over expected. So based on the picture that you paint in the EMR, we are able to understand whether that patient was expected to die. If you as a provider do not place much in your note at all about the patient's condition when they come in, one of the issues that we often see is a lack of documentation on the patient's malnutrition. Even a patient who is obese can certainly lack nutrition and have a diagnosis of malnutrition. Just kind of throwing that out there, but you are, as a provider, paint the picture of whether that patient with their comorbidities is expected to die or not. So we are looking at our observed over expected mortality, and the metrics there, anything under 1 is considered less than predicted. So right now we're trying to get our target to 1.2 and 1.1. That is still more than predicted because we have so much opportunity there. And hopefully the following year we'll be able to drop that to 1 based on our performance. But I come to this avenue to ask you as providers to continue to understand that we have an issue with our observed over expected mortality rates, to be cognizant of that and reach out to your faculty for help when necessary, but also paint the picture as appropriate with the patient's comorbidities so that coding is appropriate for those patients. And again, going down, we have the standard infection ratio for cauda, eclampsia, MRSA, surgical site infection, colon, and for C. diff. Again, we're performing relatively well in some of those, but still have opportunity because they're preventable harm regardless. And then below that are improved communication around inpatient satisfaction scores for nursing communication and physician communication. So if you deliver care within the walls of Branden Memorial Hospital, you will impact at a minimum of one of these metrics and likely multiple. Even if you practice in only an ambulatory site, the care that you delivered is translatable, right? So if someone is happy with the care that you're delivering at the ambulatory setting, they're likely to say that the physician communication during the continuing of their care, even after, over years or period of years as well. So even you have the ability to impact the physician communication. And even though it's listed as nursing communication, that as patients, they kind of put all of these in one a bucket. So really you're impacting at a minimum of both of those. All right, so at Carilion, so we have a governance structure for our consolidated quality program. So all of those things that we just talked about, we work really hard to make sure that's proactive. This is relatively new work for our organization in this way. We've kind of pieced it together in the past, but we have a program manager, Taylor Naff, over that group who is looking at improving, managing, engaging, and part of that engagement is through this, obviously, and then submission as appropriate, and then making continued improvements associated with that, then thus goes to the quality plan on the areas where we need the biggest opportunity or where we have the biggest opportunity. So medicine used to be simple, yet it was ineffective and relatively safe. Now it's complex, it's effective, but it's potentially dangerous. And that's something that for folks in a highly reliable organization, something that needs to continue to be in the back of your mind all the time. And I'll get the why. So you may have seen this before, particularly particularly if you are from Virginia Tech Carilion School of Medicine as a med student. But this is a systems perspective. It is, we have to optimize the entire environment in order to make healthcare delivery the best that it can be. And this is looking at everything. You see leadership, and you see teaming, and you see legal and ethics. And really all of this has these pieces within it that have to be up to the highest standards possible in order for patient care delivery to be optimal. And that's the EMR, the clinical informatics piece of it, the value in healthcare, the system, continued healthcare systems improvement, the processes around that, the policies and the economics around it obviously have to be there in order for all of these other things to be well. And then you have this population health piece of it. So at Carilion, we focus a lot on population health management, and because of our kind of the way that we're structured and the impact to our community. But every one of these pieces have to be optimized for healthcare delivery at Carilion to be as best it can be. And you'll see there in the middle that patient, family, and community are at the target of that. And we're talking about all of this because healthcare delivery is unsafe and is risky. And again, as a provider, you have the ability to influence that and move that healthcare being on the dangerous side, as dangerous as bungee jumping, to the highly reliable industries of commercial aviation, European railroads, and nuclear power plants. I suspect that I've asked some of you, you all are probably thrill seekers, and maybe this doesn't apply to you, but if you ask me to go bungee jumping, I'm not doing it. But what I will do is go seek healthcare, because that's what we do and kind of known to be accepted at this point. However, healthcare delivery is just as unsafe as bungee jumping. But often what you'll do without hesitation is jump on an airplane, but many people still consider that dangerous and refuse to do it. But those same people yet seek healthcare delivery, not understanding that healthcare delivery is truly unsafer than commercial aviation. But again, you have the ability to impact that through the ways that we'll continue to talk about here. So what is quality improvement? It's this formal approach to analysis and performance systematic efforts to improve it. A lot of way of saying that it's ongoing fixing of the organization's problems in a systematic way. And those are done through several of these pieces here. You'll see PDSA there in the middle. That's really Carilion's simplistic way of performing a quality improvement. You plan, you study it, and when I say you studied, I guess I jump ahead, but you plan, you want to know what you're going to be doing. I should say you research it, you do it, you perform this act, you study the results of that. And then if everything works the way that you intend it, you act on it and you institute it permanently. And it's this cycle, because sometimes there are pieces within that you have to adjust, and you need to continue to make adjustments, and quality improvement will continue to be that way. And at any point where you just stop there, then we haven't necessarily continued to improve quality. Lean Six Sigma is reducing waste. That's another one that is helpful. And when I talk about inefficiencies, the things that you see as a healthcare provider, that's one of the pieces within that. But Lean Six Sigma, reducing waste and reducing the inefficiencies within healthcare delivery, improves our patient safety. And again, I'll talk through some of that in just a moment. And good isn't good enough where better is expected. I think that I've used this slide for a really long time. There's a video associated with it. Feel free to go out there and look for 99.9% is not good enough. Good is not good enough when better is expected. In healthcare, better than better is expected. We're expected to perform our best all day, every day with the equipment. Maybe we have equipment shortages, you're fatigued, there's downtimes, regardless of whatever it is, our patients don't care. Better is always less than what is expected. We have to be at our best all the time. So kind of keep that in the back of your mind. And you, again, you as healthcare providers at Carillion influence every bit of this. And something that, if you haven't heard the term highly reliable, I want to challenge you to understand a little bit more about that. And I'll only kind of scratch the surface here, but an organization that succeeded in avoiding catastrophes, an environment where adverse events can be expected due to risk factors and complexity. That's the definition of highly reliable. So when an aircraft carrier is traveling down the sea at ever how many knots, I guess, they travel, and a fighter jet is trying to land on it, adverse events can be expected due to risk factors and complexity, right? But that organization, aircraft carriers, tend to succeed in avoiding those catastrophes because even the lowest person on that ship, even the person whose job it is to sweep the ship, to get everything off the deck of it, understands that if they do not perform their job to their best, they didn't get enough sleep last night, they're stressed about whatever, but yet if they understand that if they do not perform their job to their best, that plane may not land. They are preoccupied with failure, and that our folks who work in a highly reliable industry or organization are continuously preoccupied with failure. They understand if I do not do something right, if I'm not continuing to look out for how this may harm me, our patients, our community, then things may not turn out the way that we expect them to. And you think about these, the air traffic control. They understand, this one person up in the tower understands that essentially they have ever 200 or whatever number of people lives in their hands when they're landing an aircraft. Even an airport. So you as a healthcare provider, when you find something wrong in the electronic medical record and you don't tell anybody about it, it doesn't just impact your patient, it impacts every one of them down the line. So be preoccupied with failure. I'm going to give you an avenue to tell folks about those situations. And Starbucks, Amazon, mining, we're probably not considering them highly reliable. If you're first of all, the risk factors and complexity within the first two are not extremely high. Mining, although I would venture to say that it is, but we know that accidents exist, and if you got your Starbucks this morning, there's a relatively good chance that wasn't right, or at least you checked it, because you understand that there are catastrophes, if you will, sometime within those. So are we as successful in avoiding adverse events despite the risk and complexity in healthcare? My argument to that is no, we're working that way. That's why I'm talking to you today, so that you play a major role in that. But can we be successful? We can be successful, and I think eventually we'll get there. But again, we'll need your help, and we'll need everyone preoccupied with that failure. So being preoccupied with failure means that we have to have a culture of safety that tells us about when problems exist, and then we have to, as members of the healthcare and quality and patient safety team, have to do things about those things that you tell us about. So this is from the FAA. There's this increasing of awareness, increasing of trust. You have this, who cares as long as we're not caught doing it. There's people out there like that. I think fortunately for us in healthcare, most people are here because they want to be here. But further up to that, you have reactive. Safety is important, and we do a lot, or we do a lot every time we have an accident. So when something happens, we put all of our resources into it, but yet that's still not where we need to be. Remember, when there's an accident, there's the patient harm. So how do we get better than that? We're calculated. We have systems in place to manage all these hazards. In healthcare, that's not really, it's not as clear cut as it is with the FAA. So we have to go a little beyond that into this proactive and generative nature, where in proactive, you anticipate preventing problems before they occur, right? We need you as providers to be preoccupied with failure and tell us, I'll tell you more about that on the next slide, about what those problems are, so we can fix it so that it doesn't impact you, your colleagues, or our patients down the line. And this generative safety is how we do business around here. And that's where we need to be. We need you continue to be vigilant and understand that whenever there's a problem, I'm not writing you up. I'm not 7-safing you, which people have said before. But what I'm doing is I'm telling someone about a problem because I'm constantly preoccupied with failure, and I'm constantly vigilant in understanding how this little piece of the healthcare delivery system that I'm currently involved in today may impact our patients down the line, and really may impact you seeking healthcare delivery as well, your parents, your neighbors, whatever it may be. So how do you report? So first of all, we as an organization have to do our part, but we need you to tell us about these opportunities. So on every Carilion desktop, there's a SafeWatch logo. There's also this phone number 7SAFE. That phone number is 540-981-7233. If you are not near your computer or your phone right now listening to this, and you're just or not watching this, but you're hearing my voice, I ask you to put this phone number into your phone. It's in Perfect Serve. You can sit down and, like I said, enter this in SafeWatch. It's a little more time consuming that way. But I ask you to enter these events into SafeWatch. You are at a minimum are seeing at least 2 near misses a shift, and there are 600 or so near misses before an event actually harms a patient. That means that during your care delivery at Carilion, or you are seeing opportunities to be vigilant about patient safety. And we ask you to tell us what those are so that we can work to fix them. One of your colleagues, Dr. Howard, in OB, was awarded a Great Catch Award not too long ago because of her vigilance. And we do try to recognize folks for helping us to improve the delivery of care at Carilion. So if you get the Great Catch Award, we'll update this slide and have you in there as well. So why are we here, right? We talked about systems thinking. We talked about safety culture. Hopefully at this point, you've heard about human factors. The teamwork really it continues to be ongoing. I think there's been presentations on teaming in the past, but this is part of that, right? So not only are you on this part of this interdisciplinary team on each patient that you're caring for, but there's also this component where you are necessary in order to carry out these high reliable principles in order to make sure that we're delivering the highest quality care that we can. And this outcomes data that we talked about sometimes is lagging and sometimes is leading, but we apply those into this problem solving methodologies and these frameworks that we're going to talk about next. And then we get into the improvement of the care that we deliver. So all of these things have to occur. We have to apply these principles to it, and then we'll see the outcome of that. A little bit more about what happens at Carilion when you enter one of these events. And before we get to that problem solving framework, we work with this, again, an interdisciplinary team of human factors professionals, accreditation readiness, patient advocacy, making sure that the patients and their families are involved and in the loop in this clinical risk management. Again, SafeWatch, where these are coming through ongoing quality improvement, which is my team, process improvement through the leadership of John Schumacher. And so all of these things are within the Department of Clinical Advancement and Patient Safety. Thus, every event, we have the ability to collaborate with all of these folks. And this is something that not every institution has. So we're fortunate to have it at Carilion, but your structure at a different institution may be different. And CAPS, which is, again, the Clinical Advancement and Patient Safety partners to prevent serious safety events. So when you tell us about those opportunities that you see, because you're constantly preoccupied with failure, you report those. We prevent the harm before it occurs by fixing the concerns, hopefully, designing, implement systems that initiate or system level initiatives that ensures the health and well-being of our patients and team members. So again, these are systems-based initiatives. We're not saying so-and-so don't do that again. We're not putting training processes in place, although that may be part of it, but that's not our sole mechanism to improve quality and patient safety. We're making changes to the EMR. We're making changes to the environment. We're changing orders, and we're putting best practices in place through these system level interventions, not just telling people to do better. And we're educating support teams to lead quality improvement. So we're empowering you and teaching you these things so that within your programs, within your service lines, you're going to hopefully implement ongoing improvement work, although it may be at a lower scale. You have the ability to impact these things. And really, this is just kind of showing you that we collaborate with everyone. And clearly with GME here today, I was at the program directors meeting yesterday talking about our quality plan and data that the program directors are have access to. So GME continues to be a large part of that. Legal health analytics, which are getting reports that we need, medical staff office, ancillary departments, infection control, and others. So your event reports, the 7 saves, the things that you're telling us about, allows us to collaborate with all the right people to make sure that we get these things fixed as we should. We've talked about this a little bit, so I won't belabor that. So in your toolbox, we're going to talk about a couple of different things that we talked about on the objective slide, one of them being fishbone diagrams. And fishbone diagrams are one of the simplest way of looking at a complex problem and giving us kind of tangible pieces within that problem to solve. So we're looking at the causation. Every one of these scenarios may be a little different, but for the most part, you have 6 major bones, if you will, on that fish, and they largely report or are materials, methods, measurement, machines, environment, and personnel. So when you're looking at a problem, you're kind of looking at all of these situations, the measurements, the methods, materials, machines, environment, and personnel, to understand what pieces of each one of these may have led to that event. And I'll put it in a non-healthcare term for you, because again, this is not something that's healthcare specific. This can be applied to your everyday work. So if anybody's going to play basketball later today, I may have solved some of your problems for you. So if you're missing free throws regularly, that's our problem, right? We'll look at this, the cause of this, and we'll put it in these kind of same fish bones that we did previously. We're looking at the methods, materials, the people, the environment, and the machine, like we just talked about on the previous slide. So under the I won't go through every one of these, but under the methods, so maybe you're where you're pointing, where you're aiming, it isn't where it should be. You're not bending your knees, you're not balancing, your hand position isn't right. So maybe you didn't train well the ball, maybe the air pressure is low, maybe it's too high. So all of these things that we're kind of looking at, the size of the ball is larger or smaller than what you're typically used to in a basketball. The rim size maybe is a little different. Maybe you're playing on your kids' hoop, and that's a little different than what you played in college ball. I don't know. But this kind of same principle can be applied regardless of the work. Not healthcare specific. And so whenever you're faced with a complex problem and you're asked to problem solve that, or even if you're not asked the problem to solve it, sketch out a fishbone. It's pretty simple to do, and I think you'll be somewhat amazed at the ease of use of that. All right, for another simple one is 5 whys. So 5 whys is very simple, and it's helpful in problem solving, including human factors or the interactions. And it can be used in conjunction with others. So I'll give you this example here. This is the Washington Monument. And so several years ago, they noticed that the Washington Monument was disintegrating. They thought, and they had planned, that this was related to the jet fuel because of the nearby airport. And that jet fuel was causing the monument to degrade. And so then they had to clean it, and the cleaning was causing the monument to degrade even worse. And so their plan originally was to move the airport. They were going to move the airport And then when they kind of backed away from that, they're going to change the cleaning products because they're too abrasive. So when we really got down to this, I'm going to move to the 5 whys. This was a lot simpler than what people anticipated. And this is a real scenario. It was disintegrating, as I mentioned. So we did the 5 whys, or we didn't, they did the 5 whys with it and said the whys of monument disintegrated because we use harsh chemicals to, again, wash off the jet fuel. Why are harsh chemicals being used? To clean the pigeon poop. And there was another, they had eventually found out it wasn't jet fuel that was causing this, that it was pigeon poop that was causing it, and the harsh chemicals that were being used for it. So then they continue to go down to figure out why were there so many pigeons. Well, the pigeons are there to eat the spiders, and lots of spiders at the monument. Why are there spiders, right? Like, this is simple. They eat the gnats that are there, and there are a lot of gnats at the monument. Why are there so many gnats? Because they're attracted to the light at dusk. The Washington Monument's lights turned on at dusk before any of the other lights in the area. Therefore, the gnats went there first. So they turned the lights on at a later time. So allowed the gnats to go to a different place with less issues, less degradation issues. And so at the Washington Monument, they turned the lights on later. They didn't have to move the airport. And so sometimes in healthcare, when we don't look at this in a way like this, we move the proverbial airport when we didn't need to. We needed to do something else. And sometimes moving that proverbial airport doesn't fix the problem. That wouldn't have fixed the problem in this case. So I know I'm going a little long in time, 10 minutes or 13 minutes here, but really the moral of the story here is this can be used in a healthcare, a specific example as well. And something as simple as why was the patient not ready for transport, all the way down to, well, the patient wasn't ready for transport because there wasn't a designated area for oxygen. When you just look at the problem, you don't get there. You don't get to that solution without asking why on every question. And if you have kids, or recall being a kid, you'll know that asking why, kids want to know all the way down to the very last detail why. And that's where we really kind of need to take a step back and think, that's not such a bad idea. It really gets us to the core of the problem. You'll notice that we never stopped at a people problem here. When you stop at the human, there's typically something underlying that. So why did the human perform in the way that they did? Because their environment, or at a minimum, their training told them to do it, because their training criteria was set up that way, their orientation plan, whatever it may be. So when you're doing a 5 whys, never stop at the human, never stop at a person did this, always stop at why did the person do it? Equipment wasn't available, or whatever it may be. And again, that's how we get to a systems-based solution, not a people-based solution. So brainstorming, when we look at problem solving these events, you don't want to limit your ideas, right? When we do it, if you're involved in a root cause analysis, the way that we brainstorm these things are you shoot for the moon, and then you take a step back to understand where do we need to actually go from here? Where can we go? If our issue was a wrong site surgery, we can't just stop doing surgeries. Because of the expectation that our patients and our community have for us, but you throw all your ideas out there, including some of those wild ones, as this one says, think freely, wild ideas. We may not be able to follow through with all of those, but limiting your ideas and limiting the things that we're kind of researching there as solutions are going to limit our ability to solve those problems. And we and oftentimes use sticky notes. Doesn't work as well virtually, but certainly helpful nonetheless. And you can generate as many ideas as you can. Again, quantity counts. In some of these cases, we'll put multiple of these actions in place because some of them are easier to implement than others, and some have the ability have a level of impact that's higher or lower than others. So whenever we brainstorm, it's helpful to use an impact matrix. This is something that, again, can be applied to your either work at Carillion or school or whatever it may be, and understanding that every solution that I have, I should put it on this matrix and figure out what I should work on first, or what I should kind of get rid of. I don't need to work on because it's really difficult to implement and it has this low level of impact. And so in this case here, we got a couple of examples, and we'll show you kind of how those work. A BPA when incidental findings are reported. So it's low level when it comes to ease of implementation, but it's also low level of impact, right? A BPA can oftentimes be skipped right over, not best practice, by the way, but it happens, and we understand that because healthcare delivery, again, is complex and inefficiencies exist. So we go up to the next one, BPA with a hard stop, right? Like you actually have to interact with this. So higher level of impact, still pretty easy to implement, although technology solutions aren't always quick. And then on the ease of implementation, a lot more difficult. You have a team of people who reviews these. It's still people-based, but it has a lot higher level of impact because this is their job. So again, we may not be able to do that one because we may not be able to hire additional staff. So we may end up having to settle for a lower level solution. So this impact matrix is helpful to understand things like that. All right, strength of interventions, very similar to the to the prioritization matrix, but this is able to help us understand that some of these things, our interventions are weak, right? Their education, their policies, and their checklist. And sometimes we have to implement those, but our goal is to implement these solutions on the right side. Things that are force function. You cannot put this connector into this wrong connection. It physically will not work because if you do, bad things happen. So that's how we try our best to design things out. Whereas if we relied on the weaker intervention with that same scenario, as we just said, nurse so-and-so, doctor so-and-so, don't put this connection into this connection. But when we're fatigued and when we're stressed and when we're working, 80 hours a week or whatever it may be, we forget those things. And when you're woken up in the middle of the night to come place a central line or whatever it may be, you forget these things. Therefore, that's why we try to get the systems-based solution where this cannot go into this if it's not appropriate. And then the healthcare scenario here, using that same kind of list that we just had, the strong items have a low failure rate, the weak items have a high failure rate, and sometimes we cannot only do strong solutions. Sometimes a strong solution, maybe if we purchase new equipment, we have to have training with it, but we don't do training solely. And if we do, we add things like simulation that makes it a little more muscle memory and things like that. So when you're working in your programs to figure out solutions to everyday problems, think about this and how we need to try to engineer out solutions. And if you don't have an engineered solution, come to us so we can try to help you solve that. And lastly, we'll get into proactive risk assessment and problem solving. So again, even when you tell us about an event that occurred, which we absolutely want you to do, we're having to kind of stop what we're doing and go fix that problem. But we have the ability in healthcare to be a little more proactive. Either we're asking you to tell us again at those 600 near misses before it becomes a problem, or we're asking you to 7-safe us and tell us what those problems are. But we also have a systematic process for that calls a failure modes and effects analysis, FMEA. And that proactive methodology is a systematic data collection. It's continued hazard monitoring in some ways and creating assessment of effectiveness for safety solutions. So we're looking at how effective our solutions are and are going to be in a proactive world, and again, where we want to be. So failure modes and effects analysis. Failure modes and effects analysis is looking at systems and processes before something happens and looking at it and thinking, how can this end up with a problem. And ideally, we're actually going to do an FMEA before we bring on a new service, a new equipment. We're going to look at that and say, okay, this is a new device, this is a new process. We recently did an FMEA with newborn banding up in labor and delivery, but we're looking at the potential. So how can this fail? We're looking at the whole process. Tell me how it can fail, the modes, every way that this can fail, tell me what that is. And we're listing those out. And then we're looking at every one of those. What effect will that have on our patients? What negative effect on the process under study, right? So when we're looking at this newborn banding, the negative process is numerous. Just like in healthcare, that negative impact is often almost always death, because in healthcare delivery, it could be meaning scanning the wrong medication, scanning the wrong patient, thus giving the patient the wrong medication, sending the baby home with the wrong mother or wrong father. So that is how we're looking at the effects. If something does go wrong there, what effects do those have? And then you're analyzing the effects, and then you're looking at ways to mitigate and reduce every risk that you just identified. And that part of this is prioritizing which one of these issues has the highest potential for effect, and then making sure that those are the things that we reduce the risk on first. So very similar to many of the tools that we just talked about. And in fact, a prioritization matrix is helpful in FMEA, and a fishbone can be helpful as well. So that is an FMEA, failure modes and effect analysis. And that is a proactive risk or problem solving framework, and very helpful for you to know as a clinician and likely to be involved in at some point during your career. And then we actually have to do these things, right? We can't just talk about them. We can't just say this is what we do. We actually have to solve them, and we have to implement those strong system-based solutions and follow them through. So to kind of debrief this, I ask you to think about some of these things today, tomorrow, throughout your career. And I hope that you'll do some of these things differently or just look at them in a different way and use some of these tools that we talked about. And these are just foundation principles. You will learn and hopefully integrate more and learn more about every one of these. So far we spent 58 minutes doing this, but really this is a whole college level class, and you still won't know everything about it. But always look beyond the human mistakes. Always look for systems improvement. 7 Safe Us, place a Safe Watch, tell us where those opportunities exist. Always look beyond your immediate sphere of influence. Again, looking for systems problems, not just not that you just need to remember to not do this in the EMR anymore, but understanding that what is done there is going to impact other patients down the road. So we ask you to look beyond that. And engineered fixes are hard work, and they take a period of time, but they are necessary, and they're ultimately what impact our ability to improve the healthcare delivery for us, ourselves, or our families, our neighbors, and ultimately our patients. So that's all I've got. What questions do you have for me?
Thank you so much, Brandon. This is awesome. Things have changed so much in the world since I began in medical education. And when it was kind of the blame game when I started long ago. And now we really have moved into that quality improvement and making sure we're improving processes rather than blaming. So that should make us all feel more comfortable about being a part of the solution. Who has any questions or comments for Brandon, who's always accessible after this point, but I think it would be helpful for others to hear questions or comments as well.
Well, Dr. Ricker, feel free to share my email address. I'm happy to answer any questions or elaborate on anything, or just be there to help anyone in need. So feel free to share that.
Absolutely. Go ahead and copy paste that address into whatever you need to. If you want to talk with Brandon at a later time, get engaged in some of the projects, or just find out more about our quality improvement initiatives and the rest of what he discussed today. Otherwise, I hope you all have a wonderful day and rest of the week. Take care of yourselves.